my name is Lauren Heathcote. I previously did a PhD in experimental psychology at the University of Oxford, which is where I met Rebecca. And I studied how our cognition, particularly how we pay attention to the body and how we interpret symptoms and sensations within the body, how that relates to pain experiences in young people. And I partly studied that in relation to young healthy people as well as children with chronic pain. So I did my PhD in that, and then I just finished a postdoc where I've been for the last 5 years here at Stanford Medical School in the Department of Anesthesiology, Perioperative and Pain Medicine, where I've still been studying the role of the brain and psychology, particularly sort of cognition as well as affect, so our emotions and our mood, how those influence pain and sort of symptom experiences in young people. And I've expanded my research not just to study children with chronic pain, but also how young people with different kinds of illnesses experience symptoms like pain. So a lot of my research over the last few years have been in young people who've had an experience of cancer. And I am preparing in the next month and a half to move to London in the United Kingdom and to start a faculty position there, where I will be starting my own lab and building a team where we're investigating the role of our mind, so our psychology and our brain, in how we process physical sensations like pain within the body and how that relates to health outcomes in particularly in young people who are experiencing acute and chronic illness. Mayra, good, nice to meet you. All right, so question number 2. So you asked, given your professional experience as a specialist in pain treatment, what's the relationship between the patient's cognitive process and his response to clinical treatment? So I should say from the start that I'm not a specialist in pain treatment. So I don't treat patients myself. I'm not a clinical psychologist. Like Rebecca, I'm an experimental psychologist. So I do research on the experience of pain, and I do a little bit of research on potential sort of intervention or treatment approaches, but I don't actually deliver the treatment myself. So that's just one caveat to keep in mind. But what is the relationship with the patient's cognitive processes and their response to clinical treatment? That's a big question. That's a very big question. I think my research has focused on a slightly different but probably related question, which is how does the individual's cognition or their cognitive processes, how does that relate to their experience of pain or other symptoms more broadly? And then that probably can tell us something about how it might impact their response to treatment, as well as what kinds of treatments might be helpful and effective. So we know that pain and really any physical symptoms that we feel, so fatigue, tiredness or itch, for example, these are all outputs of the brain. So all of these things come from our brain, and really they're just signals from the brain that are designed to protect us from potential harm. So pain is a signal that's produced by the brain that's designed to protect us from tissue damage. Itch, on the other hand, is a signal that's produced by the brain that's designed to protect us from airborne pathogens. And so each of these symptoms that we experience have slightly different functions. So pain, as I say, is designed to protect us from tissue damage, and it does that by promoting behaviors that would sort of remove that tissue damage. So either we try and get away from the source of pain, like if we put our hand on a hot plate, we might quickly take it off if we feel pain to stop it from burning our skin. Whereas itch promotes the behavior of scratch, and that's to try and actually get rid of the potential airborne pathogens in the air. So the way the symptoms that we feel are really just sort of an evolutionary process that's designed to protect us and promote behaviors that protect our body. So they're quite adaptive in that sense. And because they're designed to do that, they naturally do a couple of things. One thing is that they naturally capture our attention, and attention is a cognitive process. So in order for our brain to protect us from tissue damage, when we feel pain, it has to capture our attention so that we stop doing everything else and we do everything we can to get away from the pain and to reduce the tissue damage. So naturally, pain and other symptoms, they capture our attention, and they also force us to try and figure out what's going on. So they force us to interpret the situation and interpret the pain. You know, where is this coming from? What can I do about it? And that's another cognitive process, interpretation or appraisal. So just by their function alone, symptoms like pain are sort of inextricably linked with cognitive processes like attention and interpretation. And actually so much so that one of my previous PhD advisors, Chris Eccleston, he says that chronic pain is really basically just chronic attentional interruption. It's like if you have chronic pain, it's like you're constantly being interrupted. Your attention is being captured by this pain and you can't focus on other things. So that's a little bit about how pain is related to cognitive processes. I think then, you know, how we think about how that would impact response to clinical treatment. You could imagine that, you know, if someone is having their attention constantly captured and interrupted by pain, then it could be really hard to engage with complex, difficult treatments, for example, like cognitive behavioral therapy, because their attention is constantly being interrupted by their pain. So that could mean that actually it would be tricky to engage in those things. But it also could mean that treatments that try and change the way that people are paying attention to their pain or interpreting their pain, that might actually help improve the pain itself. So in response to question number 4, what are the physiological and cognitive levels of pain recognized today by medicine? What are its main forms of treatment? So I don't know if I'm completely answering your question. There's probably a few parts to your question, but I think one way in which the field of medicine is recognized that our cognition is relevant for our pain is that the sort of gold standard non-pharmacological treatment for chronic pain is cognitive behavioral therapy. So it's therapy that we apply to and was originally developed for treating mental health conditions like anxiety and depression and things like that. And we have the best evidence that actually cognitive behavioral therapy is a helpful treatment for at least adults with chronic pain. There are other kinds of psychological therapies that involve like cognitive components like acceptance and commitment therapy, exposure-based treatments that we're starting to study now, and we don't yet have strong evidence whether they work or not, but we have good evidence that cognitive behavioral therapy works. And so I'd say that's a relatively well-recognized form of treatment for chronic pain. Challenging the cognitions, the beliefs that people have around their pain. For example, the idea that, you know, pain means that my body is damaged, and pain means that I'm continually damaging my body. Those beliefs are often challenged by pain professionals because often actually pain isn't always indicative of tissue damage, and especially when someone has chronic pain, not doing any movements can actually sort of lead them to become quite disabled. And when they do start sort of doing activities again, it might cause some pain, but it's important to help them recognize that pain isn't actually necessarily indicative of tissue damage, and that helps them to regain function again. And also it's challenging sort of at least around what kinds of thoughts do you have about your pain? Do you think that it's never going to get better, for example, and going to significantly impact your life? And how do you think those thoughts are impacting your pain? So yeah. Question number 5. So today, who are the recognized professionals of the interdisciplinary team in the pain treatment process who are part of the patient's rehabilitation? Yeah, it's a good question. I think that the treatment of pain differs quite a lot all over the world. And again, I'd be interested to hear your experiences of pain treatment in Brazil. I think it's generally agreed that the best thing that we have is, as you say, an interdisciplinary approach. And so that's multiple different medical professionals working together, right? So it's not just multidisciplinary where there's lots of professionals, but they're all kind of working separately. It's interdisciplinary, lots of professionals working together to tackle the problem of chronic pain. So you will likely, in a good interdisciplinary pain treatment program, you're going to have anesthesiologists who will think about procedures as well as medications that might be helpful for the pain. So things like nerve blocks or opioids, for example, or other medical medications. Then you'll have psychologists, a really core part of an interdisciplinary pain treatment team, who can help these individuals cope with their pain, manage their pain, get back to functioning, which is often a big focus for the psychologist as well as the pain team as a whole, is how, not necessarily can we take the pain away, but can we help this patient regain function and live a valued life. And then there is often nurse specialists as well as physiotherapists are really important parts of pain treatment teams. Again, that's a lot of that is to do with helping people regain function, helping to build muscle strength that might have gone away if the patient has been quite sedentary for a while. Getting the patient active again. And then there are occupational therapists as well, a really important member of the team, and that's often to help individuals regain their occupation. So for an adult, it might be their job and the roles that they have in life. For a child, their occupation is school. So they might work directly with the child's school to try and help the school understand the child's chronic pain and to help them better integrate back into school and do better at school. So question number 6, what's the biggest challenge that I've experienced, and how do I deal with this clinical challenge for treatment? So I think this one's, again, a tricky one because I don't treat patients myself, but I can certainly speak a little to the sort of the research side and what I've seen through other clinical colleagues. Again, I think you'd probably be better suited to answer this question yourself with your experience, but I think one big clinical challenge we face is really moving away from this like biomedical understanding of pain, that pain is directly caused by tissue damage and is a reflection of something wrong in the body, tissue damage or nerve damage, for example, and moving towards a more biopsychosocial understanding of pain, which is that pain is an output of the brain, that it's designed to protect us. And really that any credible evidence the brain picks up to suggest that we need protection will impact our experience of pain. So one of those things certainly is tissue damage itself. So we have nociceptors and nerve endings within our body that pick up changes in pressure and changes in like mechanical changes, and they tell us that there's damage in our bodies. And of course, that information is really important, probably the most important thing in explaining pain, certainly at least at an acute level when we experience acute pain. If I was to have a little paper cut, I'd experience a certain amount of pain. And if I was to have my arm cut off, I'd probably experience a lot of pain. And it's, that's undeniable, that tissue damage and that kind of information that's sent from the nerves in our bodies up to our brain is important, feeds into our experience of pain. But there are that's the sort of bio side of the biopsychosocial model, but there are other psychological and social factors that also influence our experience of pain. So I talked about how pain is about the perceived need to protect the body. And so, for example, if you have some sort of physical sensation that's picked up by the receptors in your skin and in your areas of your body, sent to the brain, there are other parts of the brain, like your memory center, that will tell you how dangerous you think that sensation is. Is this a sensation that you've had before? And last time you had it, it actually meant something was really wrong. In which case, maybe your brain will ramp up that pain experience and make it worse, because again, your brain is just designed to try to protect you. So if it's getting evidence to suggest that you need protection, then the pain should theoretically be worse. And vice versa, if your brain, you might have some sort of intense stimulation coming in from an area of your body, but if the memory centers of your brain and the emotion centers of your brain, if they actually come to the conclusion that your body doesn't need protection and that your body is safe, that could potentially dampen the experience of pain and reduce the experience of pain. And we think that, good examples of this are where people undergo surgery without anesthesia and they use meditation, for example, as a way to sort of dampen down the kind of threat centers of the brain, to be able to actually reduce the amount of pain we feel. And there are some people studying how our brain does that. And one way that it might do that is by releasing endogenous opioids. So we get them, when we're having a high, like the endorphin rush, that can reduce the pain that we feel. And we think our brain can do that, and it biologically reduces that amount of pain, but through a psychological mechanism. Attention is another one, right? It's like attention is the gateway through which we perceive the world. Our brain can only take in so much information at a time, and what we're paying attention to is what we experience. So if you're able to shift your attention away from pain, whether it's through distraction, for example, if you're having some sort of acutely painful procedure, or maybe it's changing the way that you're monitoring your body if you have pain on a chronic basis, that might impact the experience of pain and change it and maybe make it less severe, make it less salient. And then the social piece is the last piece in that biopsychosocial model, but it's really important, but it's quite understudied. How does our social context influence the amount of pain that we feel? And thinking about this idea that pain is about threat, and our brain decides how much threat there is and danger there is to our body, and then produces a pain signal based on that. There's some really interesting work by a colleague of mine called Kai Karos, looking at how when there's a social threat around you, so maybe someone who's angry and aggressive and looking to cause you more pain, how does that influence the pain experience? Does having some sort of social threat around you, again, make your brain think that there's more need for protection and therefore produce a stronger pain signal? I feel like I didn't finish my thought process. I think the challenge is moving from that biomedical model to that biopsychosocial model. And I think that it's a really challenging thing, because when we experience pain, it's so hard to not think that there's something wrong with our body. It's interesting. I should tell you, I work with many pain scientists who talk about the biopsychosocial model of pain and how psychosocial factors can influence our pain. But many of them, when they have pain themselves, they go straight to the biomedical model. It must be because there's some sort of, injury in their knee or their hip or whatever. And many of them will have surgery. And I think that just showcases how difficult the biopsychosocial model is to really accept and to integrate into our perspective. That even the pain scientists who study and understand and talk about pain as this biopsychosocial thing, when they experience pain, it's so hard. And when we all experience pain, it's so hard not to say, well, there's just something wrong. I feel it. I feel that there's something wrong. And so, that physical feeling of I feel it in my back. There's something wrong in my back. It's painful. It's not right. It's really hard to move almost away from that and say, well, actually pain is this much more complex biopsychosocial experience that's to do with all sorts of things happening in my brain. I think that's a big challenge, but for good reason. It's a good reason that that's a big challenge, because, the cultural understanding of pain and the sort of biologically adaptive understanding of pain is that it means there's something wrong, and it's very hard to ignore that. And so number 7, the last one, what's the greatest life lesson for better professional improvement and care for people with pain? I think that's another good question. I think probably the best thing that we can do as clinical professionals and research professionals as well is to believe the patient when they tell us that they're in pain. to empathize with their pain, to make them feel like we recognize their pain. And even if we can't necessarily do a test to show exactly what's causing their pain, you know, maybe they have chronic pain in their back and we do scans of the back and it kind of looks more or less normal, that doesn't mean that they don't have pain. So I think being able to validate, yes, like you clearly are in a lot of pain. I think that in and of itself is really powerful, partly because of this imbalance between, you know, pain. We think pain means there's tissue damage, and then when there's not tissue damage, then that leads people to think, well, that must mean the patient's they're making it up. It's not real pain. And that's a misunderstanding of what pain is. Pain is an output of the brain. So if the patient is experiencing pain, then that is pain. I think that's really important. There's no such thing as fake pain or real pain. It's all pain, and it's all coming from the brain. And trying to sort of allow that lesson, I guess, to help us treat and interact with patients with empathy and understanding is probably the most important thing we can do. Because if we don't do that, then of course they're just not going to trust us. They're not going to trust the medical system. And therefore they're not going to be willing to engage with anything that we can offer that might help them. I also think, although there's not a lot of evidence for this, but I think that if we think about pain as this signal of threat and perception of threat to the body, by making the patient feel validated and empathizing with their pain in a way that makes the whole social context of medicine less threatening. You're accepting and validating their pain, and therefore making the entire context less threatening. That in and of itself may well be helpful for the pain experience.